let's take a look at this from the standpoint of global aesthetics, macro aesthetics, micro aesthetics. This is a great little read if you want the criteria from the AACD. One of my friends, Scott Finley, wrote this. And a lot of this will help you even go to another level if you have interest. I do think it's impossible to do aesthetic dentistry without getting good photos. When I was at Dawson, we developed the Dawson Cavity Photographic Series, which is 21 pictures. We still use this today. But what I want you to notice is rest, E, tip down smile, and profile are right here. This is our primary ones that we use for upper incisal edge. And then these three pictures with the teeth apart is how we look at lower incisal edge position. So let's go through it, and let's first look at the optimum facial balance and look at really beautiful faces. And what I want you to think about this, we just had Dr. Gunson on our CCDB, on our online lecture series. He was an amazing speaker. But really reminding me that one of the things about having the lips and the upper and lower jaws in the right place from an AP standpoint and a width standpoint is that is a facial structure that usually breathes well. And the more we start having things back, the more that gets challenged. So without having to do fancy supplemetrics, you can take a profile picture with your iPhone in natural head posture, so the person is looking at themselves in a mirror, so they're not like this or they're not like this. You just ask them to look at a mirror, and you can take a line and drop it right from the base of the nose and look at it. You should see the upper lip about 2 to 5 millimeters ahead of the line, the lower lip on the line or 3 millimeters ahead, and the chin is going to be out 4 millimeters ahead or back about 4. So what I love about this is if I'm looking at a class 3 male occlusion like I was looking like with Brian, if you looked at him, his upper lip was actually in a pretty normal relationship, and his lower lip was more forward, which is what we see in an overclosed position. As we open the vertical, it normalized, right? There's other class 3s where you'll look at them and it looks like they're prognatic, but when you look at this, the lower jaw is right, but the upper jaw is back. And when you have a maxilla that's back, that's difficult for a general dentist to fix that. It usually means we need to help with oral surgery. So just be aware. There are a lot of people that have had mandibular setbacks when actually the maxilla was probably what it needed to move forward. You look at these two examples. This is a patient who's just pretty good lip position, but either just bucked out, probably tongue thrust or something like that. That is definitely the face for bicuspid extraction. And these type of patients, often when you look at them, if there's a lot of wear and tear and it's extreme, sometimes it's an interdisciplinary case that may involve some ortho, but bringing the jaws forward, okay, to do a better, healthy relationship, and then we do restorative that they need. This is the one that really changed me. I saw this the Monday after I went and spent the week with Bill Arnett, who was learning all this, but she came in with basically some worn front teeth, thinking about doing something cosmetically. She was probably 110 pounds soaking wet. And I started looking at her face, and everything is back. And we have a CT on her. We look at what she's breathing through here, it's almost nothing. Her affect was very, very flat. That was her occlusion, very tight and retroclined, and looking at her airway this way. So what I want you to visualize is when everything's back, this starts to get really constricted. She's severe sleep apnea, 110 pounds, like she did not face of sleep apnea at all. Completely changed the direction, and then ortho, 2-jaw surgery, and I had very little to do in that case. Did some, I think 4 restorations for her once the teeth were in a better position. Bill said that the bite indicates a problem, but the face may indicate how to treat the bite. And so that's why we start here. A lot of times we're the gatekeepers for these type of cases. If we don't see it, we sometimes live with instabilities we don't need to. Next thing is evaluate lower incisal plane. I don't know how many different lending points, so we're going to talk still a great friend. He played Division I basketball, so he's about 6'8", so I just like you to say, don't forget about the little guys, the lower incisors. And I do think we forget about them, but what I want you to remember is they are important to aesthetics. We see lower incisors when people talk, but they are also what creates the centric stop against the upper incisors. They're the ones that are carrying the load when we go to excursions, so they're extremely important, which is why I dealt with Brian the way I did, getting those lower incisors sorted out. Remember, we can reshape teeth, we can reposition teeth, we can restore teeth. You can see us repositioning a bony segment if it's too high up. Segmental osteotomies, there's lots of ways to get them in the best position. And I'm going to show you a bunch of ways today. But the thing that I want you to really visualize to make teeth look good and functional is remember that they are definitely get narrow, they're definitely a trigonal shape. The line angles are way towards the center of the tooth. It's a little blown up here, but the line angles are definitely more towards the center of the tooth compared to an upper. They have a very definitive labial incisal edge where your centric stop is, which then we have a flat piece on top, and then we have that lingual incisal edge. And we see people start, this starting to get rounded over. And it really, this is an important piece because this is what's landing against the upper cingulums. They have very small incisal embrasures, they have no lingual embrasures, and they have fairly deep facial embrasures. But keep in mind how it creates the centric stop. And when we go into protrusion of left and right lateral, it is the lower incisors that are creating those lines. So they're critical to not only aesthetics, they're critical to phonetics, and they're critical to function. We'll go through this a little bit more, but as we go into protrusion, we have the concavity of the anterior teeth where the lower incisors are riding on, and we have the condyles riding against the convexity of the convex guidance. Those do not need to be analogs. That was old analogical myths. They can be different angles, but they definitely work in harmony with other smooth back teeth. So, and we start seeing this, as I mentioned, a lot of times as teeth wear, canines will erupt kind of past the thighs, and we see centrals wearing and not really erupting much. And so that's why we get these concave planes that are not functional and they look bad. And so we want to be thinking about our best ways to get that dialed in. We never want to see this concavity, and the plane that we create can be straight and it can be convex, but we never want it concave. Right? That's just a simple bonding. But we spend a lot of time doing incisors, either in position with Invisalign or something like that, or with the help of the orthodontist, but we also do a lot of reshaping and just bonding. Because again, most of our patients that are doing stuff, aesthetically, they want to work on the top teeth first. They just do. All right, so now let's talk about the maxillary incisal edge position. I got to tell you something, this is really weird because I lectured last night in Charleston, and I'm having a struggle on what I told them and haven't told you yet, so I'm going to try to not repeat myself the best I can. Benefits of being 64, right? All right, so let's think about this. So when we have a full balanced symmetrical smile, central incisors in nature are 10 to 11 millimeters long. But that 10 to 11 millimeter long tube has to start with the correct incisal edge position, and as we measure north, we run into that region